Hi everyone, welcome to week 4 of the psych elective. So I just want to recap last week's topics. So first one was about PTSD, trauma, and stressor related disorders. So I had some different readings for you. I had that podcast that was your discussion board was based on. And in that podcast, I specifically picked this because one, not only does it kind of tell this from a patient perspective firsthand what their experience is, but it also kind of presents an issue that we face as clinicians, even as loved ones of people that are experiencing PTSD, is that maybe they are coping with symptoms or have chosen ways to cope with their symptoms that might not be what we would consider healthy behaviors or maybe good in the long run. So, David Morris said that he uses alcohol in moderation to help treat his symptoms and alleviate some of the symptoms. And he's found that to be kind of the best therapy so far for PTSD. This is not an unusual statement for people that have PTSD or anxiety disorders, that using alcohol or even cannabis in particular, that it helps alleviate their anxiety and kind of the distress that they're feeling, and they find it to be better than any medication or therapy, behavioral therapy. So behavioral therapies are generally more effective for PTSD than pharmacotherapy. But behavioral therapies can be time consuming and they can be extremely painful for somebody to undergo, because one of the primary treatments for behavioral therapy for PTSD is prolonged exposure therapy. And in this, the patient basically recounts the specific traumatic memory that's causing them the most distress. Now, there may be many, but we have the patient identify one specific one. And they recount in as much detail as possible, sights, sounds, smells, in the present tense as if they are reliving it, what happened. And this can be incredibly distressing for people. So even just to get through it once can take an entire therapy session. But the idea is what happens here is that with repeated exposure to the traumatic event through retelling or listening to yourself retelling it on an audio tape, is that each time you listen to it or hear it or think about it, the amount of anxiety, fear, physiological responses, distress that it causes you starts to diminish and dissipate. And that when you think about it or you encounter things that remind you of the trauma, that it's not as distressing. And so it can be very effective at significantly reducing PTSD symptoms. However, one major limitation of this, besides it being very difficult, is that even though it might significantly reduce PTSD symptoms, patients might often still meet criteria for PTSD, so they haven't hit that sub-threshold. So we do see a lot of people drop out of treatment, especially if they don't see any benefit after the first session or two of exposure, which is problematic. Then current pharmacotherapies are generally ineffective for PTSD. They come with more side effects than any sort of benefit, and so a lot of people don't find much relief from it. And there haven't been any new drugs developed for PTSD in a very long time. So that's one area of research people are looking at. So a lot of people that have PTSD anxiety will report they use drugs or alcohol to help alleviate symptoms because it does make them feel better. And while this might be the case, I think a lot of you commented on the fact that this is kind of a Band-Aid approach. And so are current pharmacotherapies as well, where we're kind of just treating temporarily the symptoms or kind of alleviating the symptoms that come with PTSD, the anxiety and stuff, but we're not really getting at the underlying root cause. So for instance, PTSD forms following a traumatic event. It's one mental health condition that has a specific etiology that we can tie it to, a specific event. Without a traumatic event happening, you don't develop PTSD. So it doesn't have to be one single traumatic event, but there's, usually people have experienced many things and it might manifest at different times, relevant to when that trauma happened. But what happens is during a traumatic event, you will start to associate things in the environment around you during that trauma. So let's say you're a veteran in combat and you smell, diesel fuel and hear the sounds of explosions and guns. You come back here, out of the war theater, and you are back home and you smell diesel fuel from a tractor going by, or you hear fireworks going off, and it starts to elicit these feelings in you as if you were in combat again, even though you're in a totally safe environment. There's no guns or bombs going off, but now it's evoking these memories. So these are associations that you formed. So a lot of the therapies target breaking those associations, learning when it is appropriate to respond in these extreme fearful behaviors or behavioral responses versus when you're in a safe environment. And so it's really hard for people to suppress these inappropriate fear responses when they are suffering from PTSD. Current drugs don't get at that. So one of the areas that I study is the cannabinoid system. And I know a lot of people will self-report self-medicating with cannabis because it does help alleviate their symptoms. It helps with treatment-resistant nightmares. They're able to sleep. But again, it's a Band-Aid approach. So as long as they're using cannabis, they're going to feel better. But once they stop, not only do their symptoms come back, but they come back with an increased severity. And that becomes very concerning and dangerous for the well-being of the patient. So perhaps there's other ways for us to go about targeting this system. So instead of, we all kind of agreed that maybe he shouldn't be using alcohol as the best treatment approach. But, at the same time, it's kind of how do we go about addressing that? How do we approach him with that? And so I think some really nice comments people made were approaching him in a non-judgmental manner. Inviting yourself into a conversation with him about, your thoughts about it, kind of using evidence, not just personal beliefs, but evidence as to why maybe that might not be the best approach. Offering other potential solutions. This discussion board and how to address this was purposely meant to be very difficult because this is the reality of it. If you have not gone through it and you have not experienced PTSD, which several of you have mentioned, it's hard for you to say what you would do in that situation. And when you've gone through several different types of treatments or have tried to get help without any relief, and you find something that gives you relief, that is really hard to convince somebody to stop doing without giving them an equal or better replacement. And, even going a day or a week without any relief is very difficult. So I like the approach of not just lecturing, talking down, telling me you absolutely can't do it. I like the idea of giving some other options, really kind of considering why is this patient using it? What is it that they would ideally like to get in relief? So when I've given presentations to community groups about my research with targeting the cannabinoid system, I'm not talking about using cannabis to self-medicate. I'm talking about a very different approach to targeting the system that helps boost the learning that occurs during exposure therapies. So my message is that my approach for thinking about PTSD treatment is not to create another drug or medication that people have to take every day in order to get through the day and live their lives, but something that serves as a way to kind of boost changes in the brain that occur during behavioral therapy in a way that they don't have to rely on. They don't have to take a pill every day in order to feel better. They don't have to always be dependent on something to make it through. Here, it's about giving people their lives back. And in all honesty, every person that I've talked to that has self-medicated with cannabis, when I'm done with my talk, they come up and they said, even though using cannabis every day helps me, if there was an option to take a medication, before I did my therapy, let's say I take a little dose of cannabis, right? And I do my therapy and that helps cause these changes in my brain, that helps me remember the therapy better or maintain my therapeutic gains longer, even in the absence of the drug, I would take that. I would do that in a heartbeat. It doesn't matter. I would sign up for that. And I think that's very telling, that it's not so much that people want to be using alcohol or drugs to feel better, but they want to feel better. So that's a really important point. So thank you guys for, your very thoughtful responses and kind of suggestions and approaches that you would take to this. PTSD is my specialty and my expertise, so I am very passionate about this and kind of the experiences that people go through it. So I appreciate that you guys tackled this difficult question. I also want to thank you for attending Patty Dixon's live session on Friday about student wellness. Patty Dixon's great. So, she's a great resource. She's super knowledgeable. She's really easy to contact and she responds very promptly. But I appreciate you guys being there and for your reflections on student wellness on her presentation. So I think it tells us a couple of things, right? It tells us ways in which we might be able to identify when somebody around us might be experiencing a mental health crisis. And what are some things we might be able to do to help approach that? She talks about resources. She gives us some facts and figures about mental health. And I love the comparison to physical health disease states, right? We don't often think of mental health in the same way that we think about physical health. But they are can be very much compared. And I also think that, not only is it for us to think about with mental health in other people, but also within ourselves. A lot of you guys had commented on, the experience of graduate school and the stress and the anxiety that comes with it. And you know what? I agree 100% with you. When I was doing my doctorate degree, I want to say within the last year of my program, I had a nervous breakdown. I found myself just completely unable to keep it together and sought out help for the first time. I am studying mental health conditions and I'm thinking them and me, that's them and this is us and I don't have any problems, but I do. And I still struggle with it to this day. And there's nothing wrong with that. And even if you don't have a mental health issue or haven't been diagnosed, chances are you've still struggled with stress and anxiety and even depression at times, right? And so you do have some insight into how that goes. And so I think it's important that we recognize this is totally normal. There's nothing wrong with it. There's nothing wrong with, asking for help. And there's nothing wrong with, checking in on our friends and asking questions. The other thing I want to say is that Wayne State, in collaboration with the community, has a really awesome mental health first aid program. And they have a grant fund to fund this program that allows them to provide free mental health first aid training to Wayne State students and faculty and staff, as well as community members. I did one of their mental health first aid trainings. It was an all-day event. And I highly recommend it to any of you. It helps to identify when somebody is in a crisis and what to do to help kind of give them some acute care while seeking medical help and other assistance. So I highly recommend you do that if you haven't had the chance already. Okay, for this week we've got two new topics. The first one being this idea of there's this new kind of renewed interest in psychedelics as potential treatments for anxiety, depression, schizophrenia, PTSD, a whole host of mental health conditions. And so there's a lot of research that's been going into this, but there's also a lot of controversy with it because what have been considered illicit, illegal drugs now are starting to become, the option or the promise of potentially becoming therapeutic drugs. So I've got some readings for you and then a discussion board that asks you to kind of comment on your own perception of what you think about the idea of hallucinogens in particular having any medicinal purposes. The second topic is related to movement-induced disorders. And so a lot of these movement-induced disorders come from antipsychotics. So in schizophrenia, we see a lot of movement-induced disorders. Drug-induced movement disorders due to antipsychotic use. So I have linked a video. It's an hour long. You can pause and come back and watch it, but it's an awesome video from the Psychopharmacological Institute about drug-induced movement disorders, kind of what they are, what drugs are involved in it, what they look like. And then, so that's the required lecture for you to watch. And then there's a discussion board asking you to choose a stance, you know, whether you think first generation antipsychotics are better or more, you know, at producing, you know, clinical benefit to patients with schizophrenia than second generation antipsychotics or vice versa, and then provide support for your argument. For that discussion board, unlike previous discussion boards, I want you to not only provide your argument with references, but you only need to respond to one classmate's response, okay, instead of two. For the psychedelics, that discussion board, you're still going to respond to two classmates. Also, under the drug-induced movement disorders, I've included a link to the AIMS, which is an assessment tool for looking to see if there are any drug-induced movement disorders. I've linked to a video series where it talks about how to use the AIMS assessment tool, how to evaluate a patient. So it gives you an opportunity to kind of see an actual patient being evaluated using the AIMS for drug-induced movement disorder. And then you can even practice. I've included the AIMS assessment form on there that you can practice, because this might be something very common that a lot of you might experience in practice or with patients. So the AIMS document or assessment questionnaire is something that might not be so foreign to you in practice. I've also linked a couple other types of movement assessment questionnaires as well. These are all optional for your own reference. You don't have to watch it or do any of it, but if you go to the College of Psychiatry and Neurology Pharmacists website that is linked, that's where the AIMS documentation and training is. If you go to their website, in order to view the full videos, you create a free account. You don't need to pay for anything, but you will have to create a free account if you're interested. Okay? All right. So I look forward to reading your discussion boards for these next two. If you have any questions, don't hesitate to email me, and I will see you soon. All right, take care.